Uh, we will start the today's program, PG Clinics. Uh, Chairman Dr. Rajgopal Shenoy and myself are at Mandya attending on CME, but we'll be with the clinics also. And I welcome our chairman, Dr. Rajgopal Shenoy sir, for today's program, and I request him to welcome you all and to start the program also.
Namaskara. Good evening.
Namaskara, sir. Good evening.
Nice to see Dr. Preethi Avare and
Namaste, sir.
Namaste. So I also welcome our examiners, Dr. L N Mohan and Dr. Madhu. Hello, sir.
Good evening, sir. Good evening, sir.
Namaskara.
Good evening, sir. Thank you.
Good evening,
Sir, we are doing this second week of every month, sir. This PG discussion, PG time actually. So please continue with that. So we are in a Surgeons Day celebration of the meet, some academic activity and something actually Mandya. So please continue with the discussion. Dr. Preethi, please go ahead. Best wishes to you. Okay.
Thank you, sir. Thank you so much. Good evening, everyone. I extend a hearty welcome to all of you to this Kscasi ASI online PG clinics. Today we have two presenters. One is Dr. Manoj, final year postgraduate student from JSS Medical College. He will be presenting a case of lump in the breast. We have another student, Dr. Sagar from Mysore Medical College. He will be presenting a case of swelling in front of the neck. These are the two common cases which are kept in the postgraduate exams. To examine these two students, we have a very reputed surgeons, Dr. L N Mohan, Professor of Surgery from Vydehi Medical College, and Dr. Madhu B S, Professor of Surgery and Head of the Department, Mysore Medical College. Now I request Dr. Manoj, the first candidate, to present. I request Dr. Manoj to present his case.
Thank you, ma'am. Good evening, one and all. I'm Dr. Manoj Sreenivas, final year postgraduate from JSS Medical College. Today's case discussion is about Mrs. X, a 65-year-old female hailing from Mysuru, homemaker by occupation. Patient was admitted on the 5th of June 2025 and was examined on the same day. She comes with chief complaints of pain in the right breast since 1 month and lump in the right breast since 1 month. History of presenting illness. The patient was apparently normal 1 month ago when she developed pain in her right breast, insidious in onset, pricking type, intermittent, gradually progressive in intensity, not referred, and there were no aggravating or relieving factors for the pain. Patient consulted a nearby physician for the same complaint, who on examination made the patient aware of a lump in the right breast which was initially 4 into 2 centimeter and since then has rapidly increased in size over the past month from the size of 4 into 2 centimeters to the present size of 10 into 6 centimeters. No history of nipple discharge or nipple retraction was there. No history of skin changes in the right breast. No history of any ulceration or fungation was noted. No history of any trauma to the breast. No history of dyspnea, recent onset of difficulty in breathing. No history of jaundice, seizures, or lower back ache. No history of previous irradiation to the chest. No history of OCP usage or hormonal replacement therapy usage was there. No history of any previous breast surgeries or no history of any other swelling in the other breast and both axilla. Coming to the menstrual history of the patient attained menarche at the age of 14 years and the patient attained menopause at the age of 55 years, prior to which the patient had regular cycles with normal flow and was not associated with any clots or dysmenorrhea. Obstetric history, the patient had an obstetric score of P3L2. The patient had the first child at the age of 30 and was breastfed the child for 1 year bilaterally, a full-term normal vaginal delivery. The second child, which died at birth, was at the age of 33, with the cause was unknown with no details available. The third child she had was at the age of 36, breastfed the baby for 1 year bilaterally, and this was delivered through an LSCS. Coming to the past history of the patient is a known case of hypothyroidism on tap thyronorm 62.5 micrograms per oral once daily since the past 30 years. Patient is a known case of type 2 diabetes mellitus on OHS since the past 12 years. And patient is a known case of systemic hypertension on regular medication since 12 years. Patient underwent LSCS 29 years ago with no other significant surgical history. Patient underwent a USG guided biopsy for the right breast lump on 17th of May 2025. Coming to the personal history of the patient consumes a vegetarian diet. Patient has not been getting adequate sleep in the past 1 month due to the pain, and the patient has adequate appetite. Patient has regular bowel and bladder habits. Patient has no habits of smoking or chewing tobacco or consuming alcohol. Coming to the family history of the patient has no significant family history or no other history of any other cancers in the family. Summary. To summarize the history, she's a 65-year-old female with hypothyroidism, type 2 diabetes mellitus, and systemic hypertension on regular medication. And she comes with complaints of a painful lump in the right breast since 1 month, which has rapidly increased in size and with no other significant history. Should I continue, sir?
Dr. Preethi, can I say
Yes,
something?
sir. Please, sir. Yes, sir. The
I
examiners
think
can pose
Dr.
questions
Manoj,
to the student.
Thanks.
very good presentation. I think you've covered everything. The only thing is that you said there's no family history of cancer.
Yes,
Maybe you should be a little bit more specific and mention that there's no history of family history of cancer in the near relatives. I think that would be more relevant.
Yes, sir. Yes.
Dr. Madhu, would you like to say?
So, come to first slide.
Madhu, sir. Sir, I think so. There are multiple devices in your room. So can you just switch off any one, sir, from Zoom?
Multiple
That is the reason why it is echoing, sir.
Okay. Now, hello.
No, sir. It is still echoing, sir.
No, it's okay now.
Yes, sir. I
Yes,
think
yes, sir. Now it is okay.
you're audible now.
I'm audible now.
Yes, sir. Yes, sir. We can hear you.
Okay. So, patient has come with history of pain. No,
Yes, sir.
where was the exact pain?
So she said it was in the right breast, sir. She pointed towards the right, the lateral part of the right breast, sir.
Okay, without any history of any lump.
No, sir. She developed the pain for which she went to a nearby physician who then
Okay.
examined her and made her aware of her swelling, sir.
Okay. The duration is
So only 1 month, sir. 1 month
1
history.
month. Okay. There is no history of nipple discharge.
No, sir. No history of any nipple discharge, sir.
What's her age?
So she's 65-year-old, sir.
65-year-old. So,
Yes,
what type of discharge you are worried about?
So given the age of 65-year-old and the 1 month history, I would be worried about any serous or a bloody discharge from the nipple, sir.
Okay. Multiple opening or a single duct?
Sir,
Single.
multiple, sir.
Single. Recent onset.
Recent one.
Recent. So, retraction of nipple. What type of retraction you are worried about?
Sir, circumferential retraction of the nipple was what I would be worried about, sir.
No, more, onset. Depending on the onset, what type of retraction you are?
Sir,
Recent.
so recent is like, sir.
Yeah, recent. So, it
Recent
may be
history, I would be worried about a slit-like
unilateral recent retraction of nipple.
nipple. Yes, sir.
So straight away you have gone to ulceration and fungation. Before that, you don't want anyone to ask any about skin changes, any other skin changes.
So I've mentioned there's no history of any skin changes in the right breast, sir.
Okay. Next slide. So why you want to know about irradiation to the chest?
Sir, given the age and given the symptoms that the patient has presented with, I wanted to know if there's any irradiation to the chest at an early age for the patient, sir, because any irradiation to the chest acts as a risk factor for any future breast malignancy.
For what condition? For what condition?
Breast malignancy, sir. Condition for this thing is
No,
for
you are
any
assessing
lymphoma.
what are you assessing by asking this question?
Sir, if the patient has had any.
You are ruling out the risk factors, no?
Yes, sir.
You are ruling out the risk factors. So what
Yes,
risk she will have for if she is exposed to irradiation? For treatment of what condition? At what age?
So Hodgkin's lymphoma at a young age, sir.
Yeah, Hodgkin's in the
Yes,
young age.
yes, yes.
During young age.
Yes, sir.
So you have covered all the risk factors. Have you evaluated all the risk factors?
So, yes, sir.
How will you classify risk factor? Evaluate.
Sir, sir?
Risk factors affecting the breast carcinoma.
Sir, there are modifiable and non-modifiable risk factors, sir. Non-modifiable risk factors are the age, sex, genetic, familial history, genetics of the family, sir. And in modifiable, we usually have smoking, alcohol history, this thing, nulliparis, whether they are breastfed their children, and in non-modifiable again, whether it's menarche, age of menopause, we'll have to. Those are the factors we're looking for.
Next slide. Regarding family history, what you asked in detail. Family history.
In family history, I asked the patient if there was any previous history of any breast malignancies, any GI malignancies in the family, any ovarian malignancies in the family. I've asked, sir. There's no history of any other malignancies or any other.
Relative. So usually in first degree relatives, you are supposed
first
to
degree
ask.
relatives, yes, sir.
Yeah, first degree relatives. Next. Pass. Previous surgeries.
So patient has not undergone any previous surgeries, whether any in for the breast or any other surgical history, except for the lower cesarean section, sir.
So if she has undergone breast surgery
previously
for any benign condition, which condition you are worried about?
Sir, sir, I didn't catch.
Benign condition.
So previously, any benign condition could be any fibrocystic disease, sir.
No. It's which is high risk for
Sir,
potential for going.
lobular carcinoma in situ, sir.
No. Benign. Something related to ductal. Atypical ductal hyperplasia.
Yes, sir. Hyperplasia of epithelial hyperplasia with atypical.
So if you excite the lump, it comes as atypical ductal hyperplasia.
Yes.
You should be careful. Continuous monitoring. You have to monitor the patient.
Yes, sir.
Sir, Mohan, sir.
Thank you, Dr. Madhu. I think you've covered everything. Dr. Manoj, what is your diagnosis from the history? What would your first diagnosis be?
So my first diagnosis.
And why do you say so?
So for my first differential diagnosis for this patient would be a right breast carcinoma, sir, a malignant disease of the breast. Given the patient's age, sir, which is 65 years, the rapid progression in the size of the breast lump, the late first pregnancy, sir, she's had it at the age of 30, which is a risk factor. Though those three factors are what is guiding me towards it being a malignancy, sir.
You're right. Also, the short history, although sometimes the patient may not have noticed the lump, it could have been there earlier. We don't know. She's saying it's there for 1 month.
1 month.
It's possible that it's been there for some time and she had not noticed till it grew inside us. So I'd agree with you that you'd think of malignancy. Can you go ahead with your physical exam?
Yes, sir. Thank you, sir. So coming to the general physical examination of the patient, sir, she's an elderly female, well-built and obese, conscious and cooperative, well oriented to time, place, and person, sir. The pulse was 82 beats per minute, blood pressure 128 by 90 mm of Hg, sir. Respiratory rate was 14 cycles per minute. She has a BMI of 35.6 kg per meter square, a height of 150 centimeter, and weight of 80 kg, sir. She has no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema, sir. Coming to the local examination, so the patient was examined in a well-lit room with due consent and with adequate exposure from the neck to the waist in supine sitting and recumbent position with hands by her side, hands on the hip, and while leaning forward in the presence of a female chaperone, sir. In the inspection in the sitting position with the arms by the side, the right nipple areolar complex appears at the same level when compared to the left nipple areolar complex, sir. Bilateral nipple areolar complex appeared normal. There was fullness noted in the upper outer quadrant of the right breast when compared to the left breast, sir. Skin over the right breast appears normal on inspection and right arm appears normal, sir. On raising both arms above the head, sir, the right nipple areolar complex was seen at a lower level than the left nipple areolar complex. There was no evidence of skin changes noted on raising the arms above the head, and the bilateral inframammary crease appeared normal, sir. On asking the patient to bend forwards, both breasts fell forward freely, sir. The right axilla appeared normal, and inspection of the left breast and the left axilla is also normal, sir. On palpation, sir, the left breast was normal on palpation. On palpation of the right breast, there was no local rise of temperature. A solitary tender lump of size 10 into 6 centimeters was present in the right breast in the upper outer quadrant, lower outer quadrant from 7 o'clock position to 11 o'clock position, and was also seen extending into the central quadrant, sir. The lump was hard in consistency. It had an irregular surface with ill-defined borders. The lump was noted to be moving with the breast tissue, sir. The lump was found not to be fixed to the underlying muscle and skin. There was no nipple discharge noted on expression, sir. On examination of bilateral axilla, a clinically palpable mobile lymph node was present in the central group of the right axilla of size 2 into 2 centimeters, firm in consistency, sir. Left axilla on palpation was found to be normal, and bilateral supraclavicular fossa, there were no clinically palpable lymph nodes noted, sir. On percussion, there was no dullness noted over the parasternal area. With the systemic examination of the patient, sir, the respiratory system, normal vesicular breath sounds were heard. There were no added sounds, sir. Per abdomen examination, it was soft, non-tender. There was no organomegaly palpated, or there was no ascites, sir. On CNS examination, there was no abnormality detected. On musculoskeletal system, there was no bony tenderness present. On CVS examination, S1, S2 was present, sir, with no added sounds. And on pervaginal examination, both fornices were found to be empty. And on perrectal examination, there were no Blumenschelf nodules felt, sir. My diagnosis is right breast carcinoma, sir, clinically found to be T3N1M0, sir, stage 3A.
Yes, thanks, Dr. Manoj.
Thank you, sir.
You have examined in the sitting position the patient leaning forward.
Yes, sir.
And you said, did you examine in the supine position also?
Yes, sir. Supine position also I've examined.
Also?
Yes, sir.
Okay, okay. I think you have described the lump. I just want to ask you 2-3 questions. One
Yes,
is,
sir.
you said that the skin is normal.
Yes, sir.
What did you look for? And even if it's a negative finding, you should mention some findings. What are the findings you look for?
Sir, no. Firstly, on inspection, we will look for any ulcerations, sir, any erythematous changes, any nodules, any fungation, and we'll also look for dimpling, puckering of the skin, pudy orange, sir. We will be looking for.
Correct. And remember that sometimes you'll find the nodules not only over the tumor, it could be in other areas of the breast as
Yes,
well.
sir.
So
Yes.
even if it's a negative finding, mention it.
Yes, sir.
Number two, you see, it's always good to mention about the presence or absence of supraclavicular lymph
Yes, sir.
because the breast can also metastasize to the supraclavicular node. The same. I know that you said that on general exam there is no lymphadenopathy, but in your local exam, when you talk of lymph node examination, mention that the supraclavicular nodes are also not palpable. I think you've written it there. Yes.
Yes, sir. I have mentioned.
And in your abdominal examination, you said no organomegaly.
Yes, sir.
What do you mean by organomegaly? Which particular organ are you looking at or looking for?
I'm particularly looking for any liver enlargement, sir.
Yes. So therefore, better to say that there is the liver is not palpable. Rather than saying organomegaly, because organomegaly may include kidney, it may include spleen, it may include something else. So therefore, it is always better to say that the liver is not palpable.
Palpable, yes.
Dr. Madhu, would you like to comment?
Manoj,
Yes,
Dr.
sir.
Manoj.
Yes, sir.
So fixity of the lump, did you describe that?
Yes,
fixity?
sir. The lump is not fixed to the skin or the underlying muscles, sir.
Okay. What muscle?
So the pectoralis major and the serratus anterior are the two muscles I am looking for, sir.
So when you made it to bend forward, it was falling freely?
Yes, sir. Yes, sir.
So if it is attached to chest wall, what happens? If it is fixed to chest wall?
So if it's fixed to the chest wall, the affected breast will not freely fall as compared to the left breast, sir. There will be there will be lag in the fall of the breast, sir.
Okay. So what do you mean by chest wall? What is it?
So the chest wall involves the ribs, the intercostal muscles, the serratus anterior, and the latissimus dorsi muscles, sir.
Axillary lymph node, how many lymph nodes are there?
Sir, I could palpate one lymph node in the right axilla, sir, of size 2 into 2 centimeter in the central group. It was firm in consistency and mobile, sir.
Mobile, okay. 2 into 2 centimeter.
2 into 2 centimeter, yes, sir.
Nipple areolar complex, did you palpate it?
Yes, sir. Nipple areolar complex, the mass was in the central quadrant, sir. It was extending from the right upper and lower quadrant into the in the retroareolar, in the central quadrant. But the nipple areolar complex is normal on palpation, sir.
Abdomen, what are the things, as sir asked, what are the things you wanted to see in the abdomen?
One was hepatomegaly, sir. And I would also want to check for ascites, sir.
And any other thing?
Sir, any pelvic mass, ovarian mass?
So what's the mode of spread?
Sir, it's a transcoelomic spread, sir. It's through the path of Gerota, sir. So the lymph node travels through the lower, if it is in the lower quadrants, it passes to the diaphragmatic lymph nodes, and through the diaphragmatic lymph nodes, it gets spread to through the coelomic, transcoelomic spread into the abdomen, sir.
Okay. Bony pain, which bone did you examine?
So bony is lumbosacral spine tenderness I looked for, sir.
Why there only that region?
Sir, that is the usually the first site of bony metastasis. First site of metastasis of breast is to the lumbosacral vertebrae, sir.
No, why it is fond of that region?
Sir, it's because of the drainage, sir. The Bateman's venous plexus it drains there and goes to the lumbosacral region, sir, from the breast.
Lumbosacral.
Yes.
So your final diagnosis is?
So my final diagnosis is a right breast carcinoma, sir, clinically found to be T3N1M0, stage 3A, sir.
So whether it is locally advanced or what?
Sir, it's a locally advanced breast carcinoma, sir.
So it's a locally advanced breast
Yes,
carcinoma. Yes, sir, Manoj.
Mohan, sir, would you like to ask some questions?
No, I would just like to say that Krukenberg tumors generally occur in premenopausal females, as
yes.
because the ovary would be functional, and therefore these tumor cells can deposit onto the surface of the ovary.
Yes.
Please proceed. Proceed. How would you evaluate and how would you proceed?
Sir, for this patient, I would like to get a mammogram done, sir, mammography. of the right breast, sir. And I would also like to get a USG guided FNAC of the right axillary lymph node, sir.
Mammography of which breast?
And true cut biopsy of the right breast lump, sir.
So you should start like this as a part of triple assessment.
Yes, sir.
You should answer like this.
Yes, sir.
So I have done clinical examination. I go for radiological investigation.
Yes, sir.
So why you want to get done mammogram of affected breast?
Sir, the mammogram of the affected breast, given that it's an elderly female, she would. I want to get a mammogram done to look for the size of the lump, and also if there's any microcalcifications, and to look for the typical characteristics of a malignant tumor.
Already there is a lump, no?
Yes, sir.
You know, a hard lump is there. Still, you want to get it done mammogram?
Sir, to check for if there are any other lumps in the breast, sir, other than the one that we are palpating, if there are any.
You are planning for what?
So for breast BCS, breast conservation.
Yeah. You're planning for breast conservation,
Yes,
multi-centric disease.
Yes, sir.
So other lesions you have to look for
in the breast. Yes,
so you
sir.
have to do mammogram of both breast now.
Both
not only one breast.
Yes.
So no mammogram of the both breast.
Bilateral breast. Yes.
Okay. What are the features you will appreciate now?
Sir, we will see microcalcification, sir. We will see spiculated margins. We will see skin thickening, sir. We will see.
What are the ductal architecture?
So the architecture will be distorted, sir.
Okay. Next, what you want to do?
Sir, I would want to do a true cut biopsy of the lump, sir. USG guided, preferably. And then with the USG guided.
What you want to know in true cut?
Sir, in true cut biopsy, one is to we have to confirm the diagnosis. Second is to stage the disease, sir. Third, we want to know if the hormonal status of the receptor status of the lump, sir.
So what are the things you want to know? One is ERPR and HER2-neo.
And then the index, the Ki-67 index, the proliferative index also I would like to know, sir.
So we want to know these things.
Sir, these things helps us in planning for further management, sir. Whether the patient can be subjected to hormonal therapy, or if we have to go ahead with chemotherapy. We have to neoadjuvant chemotherapy.
How will you classify subtype now based on this finding?
Sir, there is lobular A and
luminal.
Sorry, luminal A and luminal B, sir. Luminal A is ERPR positive, HER2-neu negative, and Ki-67 is at the lower index, sir. And in luminal B, it is ERPR negative, HER2-neu positive with Ki-67 of a higher incidence, sir.
Dr. Manoj?
Yes, sir.
You said that you can stage the disease by doing a true cut. Can you explain that? How do you stage the disease by doing a true cut biopsy?
So
I think what you meant.
Sorry, sir. I meant grading of the tumor. Grading of the tumor. If it's a
grading,
low,
not staging.
Not staging. Right. Grading, sir. Low, intermediate, and
right.
high risk tumors.
My question to you is, why do you want to do a lymph node FNAC? What is your idea and what is your plan?
Sir, because if we were planning for breast conservation surgery, sir, I mean, if we were planning to do whether axillary lymph node dissection, we need a positive lymph node status. If it can be reactive or it can be metastatic, sir. If it was metastatic, I would like to go ahead with axillary lymph node dissection. If it was reactive, this thing lymph node reactive lymphadenitis, I would like to go ahead with sentinel lymph node biopsy, sir.
You see, the only problem with that answer is that your FNAC may not be very conclusive always, number one.
Yes. Yes,
number
sir.
two, in the presence of a malignancy in the breast,
yes, sir,
and with a palpable lymph node, you would presume that this lymph node is metastatic until proved otherwise.
Until
You understand? So I'm not sure whether FNAC will be accepted by everybody. There's nothing wrong in doing it, but if it is negative, don't think that it is Dr. Preethi, at this point, can
Yes,
we
sir.
ask the participants if they have any doubts or any questions?
So I posted in the chat
There
box,
are
sir.
about
If
some.
there are any questions, they can post it on the chat box, which will be discussed. But I'm seeing
Right.
only one question. If there are any other differential diagnosis, this question was posted at the end of history. At the end of history, would you like to think
Right.
of any other differential diagnosis?
Dr. Manoj, would you like to answer that question?
Sir, in any other differential, so I do not have any differential, sir. I would.
Unlike this, age of the patient, mode of answer. So yeah, you should suspect only one diagnosis.
Correct. I think in this particular case, you can say that I don't have a differential because you can't think of a benign disease and you can't think of Phyllodes tumor, which is unlikely to occur at this stage and with such a short stage.
Yes.
So therefore, most probably you can say that it is carcinoma of the breast.
Right breast, yes.
Please proceed, Manoj. Sorry. Go ahead, Dr. Preethi.
There are just few other questions. What is the role of sentinel lymph node biopsy in this case?
Ma'am, if the on the table, I mean, like if the FNAC comes out to be reactive lymphadenitis, we would like to do a sentinel lymph node because sentinel lymph node sent for frozen section. If it turns out to be again reactive, then we will not go ahead with axillary lymph node dissection. If it on table the frozen section comes out to be malignant, then we can go ahead with axillary lymph node dissection, ma'am.
How many lymph nodes would you like to harvest?
Ma'am, 10 lymph nodes at the minimum, ma'am.
Regarding investigations,
Yes, ma'am.
What is the recent management protocol? What is the latest update on BCS? These are the few questions posted.
Ma'am, I didn't get.
Sorry, the way it is written. What is the latest update on breast conservation surgery? These are the questions which are posted. One more question is why TrueCut biopsy is a must here and not FNAC?
Ma'am, because
how
given
TrueCut is better than FNAC?
Ma'am, because you're given the stage of the disease that is T3N1M0, ma'am, I would like to go ahead with neoadjuvant chemotherapy before surgery. So if I want to go ahead with neoadjuvant chemotherapy or hormonal therapy, I would like to know the hormonal receptor status of the tumor, ma'am. So if with an FNAC, I cannot do a receptor immunohistochemistry. So I would like to do a TrueCut biopsy, get my immunohistochemistry report, and depending on the report, I would like to go ahead whether I want to do hormonal therapy or chemotherapy, ma'am, to downstage the disease and then plan for surgery.
Any other questions from the examiners? Or can you continue with the rest of the presentation?
I think his answer about TrueCut biopsy is correct. The only other thing I would like to suggest is that if somebody asks you what investigations you want to do,
yes, sir,
you can classify them as specific and routine, and
sir.
also diagnostic. Number one, diagnostic, and number two, to stage the disease.
Stage the disease.
When you're dealing with the malignancy,
yes, sir,
you also want to do certain investigations to stage the disease. So first is to confirm your diagnosis.
Yes, sir.
And once you confirm, you need to do an investigation. So that's how you can classify your investigations.
Yes.
So can you proceed with your investigations? Presume that the TrueCut has come as a ductal carcinoma, infiltrating invasive ductal carcinoma.
Manoj, do you have investigations of this
How
patient?
would you proceed?
This was the mammogram report, sir.
It's too small. Can you just tell us the ultimate diagnosis?
How do I zoom?
You can't read.
It's okay, Manoj, you can read it.
So it's a well-defined homogeneous lobulated round opacity noted in the right upper outer quadrant measuring 5 into 4.5 centimeters. No skin thickening or nipple retraction. Suspicious for malignancy. BIRADS 4. Multiple round radio opacities with noted in the were noted in the axillary region, largest measuring 28 into 20 mm, likely axillary lymph nodes. Few calcifications with central lucency noted in the right upper outer and inner quadrants, largest measuring 28 into 20 mm in the upper inner quadrant. Nipple areolar complex appears normal. Left breast composition type B, scattered areas of fibroglandular density. Few round calcifications noted in the upper outer quadrant, largest measuring 21 into 10 mm. And multiple round opacities noted in the left axillary region, largest measuring 2.8 into 2 centimeters, likely axillary lymph nodes. Both breast of type B, right breast BIRADS 4 and left breast BIRADS 1.
What is BIRADS 4? What do you mean by?
So BIRADS 4 is highly suspicious of so BIRADS 4 is so intermediate risk, sir. So it is around 10 to 50% of malignancy risk. So I would is like intermediate risk of breast carcinoma, I mean malignancy, sir.
Next, what do you want to do?
Sir, the images of the mammogram have please.
I think what is important in the mammogram is also the additional calcification that they have noted
Yes, sir.
on the same side. So that is one important thing. Second is they've said that there's a lymph node on the opposite side.
Sir, the imaging says there is, but there were no palpable lymph nodes.
No
Sir.
clinically palpable nodes.
Palpable, no clinically palpable lymph nodes.
Right. What was your true cut biopsy report?
Sir, true cut biopsy. Sir, it showed a poorly differentiated high-grade carcinoma, sir. Malignant tumor composed of sheets of tumor cells having round to oval hyperchromatic nuclei and scanty cytoplasm, many mitotic figures and apoptotic debris seen, focal area of necrosis noted, poorly differentiated high-grade carcinomas.
What was the receptor status?
So the receptors were, sir, it was triple negative, sir, with a high index of Ki67, 65 to 70%, sir, of tumor cells were positive for Ki67.
So what's your inference with this report?
Sir, it being
With the
a
biopsy
triple
report?
negative with high Ki67 index, it is the prognosis is poor and it's a highly aggressive carcinoma, sir.
So how would you proceed? How would you further evaluate this?
So further evaluation, sir. So because it is a highly aggressive tumor, I would go ahead with PET CT, sir.
Go ahead. What findings do you expect, and what do you have the reports with you?
Yes, sir.
You said chest X-ray.
So chest, no, I said like I placed a chest X-ray, but I would like to go ahead with a PET CT scan, sir.
Is the chest X-ray normal?
Sir, there is increased
It-
bronchovascular markings, but there are no cannonball metastasis as such noted, sir, or no effusion as such.
What are the other features of? Correct. So you also look for a
Pleural
effusion.
effusion, yes, sir.
Remember. So that doesn't seem
No, sir.
doesn't seem to be present.
No, sir.
Proceed.
So this is the PET CT report of this patient, sir. A 4.8 into 4.5 into 4.9 centimeter, well-defined lobulated soft tissue density heterogeneously enhancing metabolically active mass lesion involving outer quadrants of the right breast, carcinoma breast, no evidence of chest wall or cutaneous infiltration. Bilateral axillary lymph nodes with fatty hilum, likely reactive nodes. Other subcentimetric bilateral axillary and deep pectoral lymph nodes are seen. with no abnormal FDG uptake noted in these nodes. There are no obvious hepatic metastasis, and there were no other active regions noted.
So what are the
Therefore,
indications?
sorry, please go ahead, Dr. Madhu.
Indications for PET CT. You want to do when you want to do PET CT?
Sir, when there is one is when there is excessive, I mean, locally advanced tumor.
All locally advanced are
Sir,
indicated.
sir,
You want to do in all locally advanced cases?
sir, only in high grade carcinoma, sir, where they're very aggressive and can spread rapidly. With lymph nodes positive, then we'll have
As
to.
per the guidelines, when you are supposed to do PET CT? I think it is only in recurrent cases.
Recurrent case.
Recurrence. Huh?
Yes, sir.
Recurrence PET CT is done. Now, as per protocol, you have to do CT chest and CT abdomen.
Abdomen, yes.
Because patient won't be affordable PET CT. So,
Yes.
in your institute, are you doing PET CT?
So yes, sir.
For all the patients?
Not
Locally advanced.
all, but when the patient's affordable, PET CT is done, sir.
Sir, Mohan sir, PET CT indication, sir, here.
I think you're right. See, as far as the exam is concerned, you can always say that if PET CT is available, that's a good investigation in certain individuals.
Yes.
But suppose the patient cannot afford a CT also, you can even do an ultrasound of the abdomen,
Ultrasound
because
abdomen.
that is
Yes,
still
sir.
a reliable test to look
Yes.
for metastasis, to look for ascites and pelvic tumors, and also a chest X-ray. A chest X-ray is mandatory.
Yes, sir.
But if the patient can afford a CT or a PET CT, that would be the gold standard, obviously, a PET CT. And as Sir said, it is in advanced cases or recurrent cases, it is usually more indicated.
Yes, sir.
Blood investigations, what you want to do?
So blood investigations in this patient, I would like to do the regular workup, sir. I want to do the specific, firstly
Specific.
LFT, sir.
Why?
LFT, sir, because any liver metastasis, there will be derangement of the liver function, sir.
Apart from that?
Sir, apart from that, markers, I would
Significance
like
of
to do
alkaline
tumor
phosphatase.
markers.
No, alkaline phosphatase significance.
So alkaline phosphatase is any bony metastasis, alkaline phosphatase will be elevated, sir.
What's the normal level? When you will suspect bony mets?
Sir, more than 120, sir.
300, I think. Above 300 is
Above 300, yes.
bony mets.
Yes,
Then
sir.
you can go for PET CT, I think. Bone scan and PET CT.
Bone scan.
Sir, Mons.
Yeah, thank you. So this appears to be localized to the breast from the
Yes, sir.
PET CT report.
Yes, sir.
So can you tell us how you would proceed? Does it alter your staging in any way, or do you think it's the same clinical
It's
stage?
this, sir, it remains the same, sir.
All right. So how would you manage? So now your stage is T3, you said.
Yes, sir.
T3,
T3N1
N1.
M0 clinically, sir. Yes.
So this corroborates that, except that the size appears to be slightly smaller, but clinically you said it is 10 by 6.
Yes, sir. This was done
So
3 weeks prior to the day I examined, sir. So since then it had
So
rapidly
therefore,
increased.
correct. So you would stick to T3, although the PET CT report is showing a smaller
Yes, sir.
size.
Because the
Your
clinically the
clinical
size is 10 by
examination
6.
is more reliable. So T3, how would you manage this patient?
Sir, I would, in this case, firstly, I would like to give the patient neoadjuvant chemotherapy, sir. Given that it's locally advanced with lymph node clinically palpable lymph node, I would like to go ahead with neoadjuvant chemotherapy and downstage the disease and then plan for surgical intervention, sir.
How will you assess the response?
Sir, firstly, we would like to do an assay, sir, to see what chemotherapy can be given. The response is through response as in after giving the neoadjuvant chemotherapy, sir, or like whether which neoadjuvant chemotherapy.
How will you assess the response? So
Sir,
you want to downstage the disease now?
yes, sir.
How will you assess the response?
So we will subject the patient to neoadjuvant chemotherapy and then by palpation check for any reduction in size, sir. And imaging also.
Based on the percentage.
Yes, sir, percentage.
How will you assess the response?
Sir, so usually there is complete responders where the masses completely disappear, sir, and there are partial responders where there is more than 30% of reduction in size. There is stable responders where there is less than 30%, and there is progressive disease where the size increases even after neoadjuvant chemotherapy, sir.
So what precaution you will take before starting chemo, neoadjuvant chemo?
Sir, we should make sure the biopsy is, the true cut biopsy is done even before.
Okay, that you are done. That you are done. Diagnosis is confirmed. You are done PET CT.
Yes,
Before
sir.
starting neoadjuvant.
So we'll need to mark the region to give.
Yeah. How will you mark it?
Sir,
How will you mark?
Sir, we mark it with by placing needle markers.
Titanium clips
Or
usually.
clips can be placed, sir. Clips can be placed in the region of the
Center of the lesion.
Sir?
Center of the lesion. Like
Center of the
titanium
lesion,
clips.
yes, sir. For future
Titanium
radiotherapy to be targeted at that point.
No, when you're planning for excision, you need if there is a complete response,
yes, sir.
You won't be knowing where is the lesion.
Yes, sir.
So if you keep a mark, you can plan for a
yes,
procedures, your BCS.
Yes, sir.
Can you tell us which chemotherapy drugs are used and how many cycles you give?
Sir, in there, depending on the receptor with the HER2/neu, whether if it's negative, we use first line is adriamycin with cyclophosphamide, sir. And then that is our first line thing. And after 2 weeks, we will reassess the response. If the response is poor, then we will go ahead and use the second line chemotherapeutic agents such as paclitaxel, sir.
How many
cycles are given?
So totally 8 cycles are given, sir.
All right. Presume that the patient has responded after 3 cycles, and when you go back and palpate, the tumor has become smaller.
Yes, sir.
What is your plan?
So I would like to continue with chemotherapy, sir. Till we complete 8 cycles and then plan for surgery.
All right. What surgery would you want to plan?
Sir, with if there is complete response, then I would like to do a total mastectomy, sir.
MRM. MRM. No? You want to
Like
do total mastectomy or MRM?
Dr. Manoj, it is not enough if you say mastectomy. Can you be a little bit more precise?
So modified radical mastectomy can be planned, sir.
I think that would be expected.
Yes, sir.
In your exam as well.
Yes.
Because if you just say mastectomy, it means that you are not addressing the lymph nodes.
Yes.
And you're just removing the breast with the overlying skin and subcutaneous tissue. So I would say that MRM would not be acceptable in this patient if it responds.
Yes, sir.
Dr. Preethi, any questions or yeah?
So in the chat, I'm seeing what are the drawbacks of mammogram?
Drawbacks, I think it's a very sensitive investigation because it will pick up early lesions, it will pick up calcification, it will pick up multicentric lesions. But sometimes if it's a recurrent tumor or if it's,
Younger female.
an MRI would actually be preferred if there's a recurrent tumor or
Yes,
a
right.
residual tumor. So otherwise, a mammogram is a very good initial investigation in the first sitting.
Yes. So most of the questions posted in the chat have been covered. So if there are any other questions from the examiners to Manoj, Dr. Mohan sir or Madhu sir, if you want to pose any other questions to Manoj.
Manoj,
Yes, sir.
so what are the structures preserved in MRM, modified radical?
So the structures preserved are as an axillary vein, long thoracic nerve, and nerve to serratus anterior, sir.
Okay.
My question to Dr. Manoj, suppose this lady turns out to have metastasis, suppose it is M1,
Yes, sir.
how would it alter your management?
Sir, I would go ahead with palliative chemotherapy, sir.
Okay. Is there any role for any type of surgery in such a situation?
Sir, downstaging surgeries or metastatectomies can be done, sir. Debulking surgeries can be tried.
Yeah, I think you're basically right. The treatment would be palliative because obviously the prognosis is very poor, and therefore there's no question of any major surgery. What we used to mention was something called a toilet mastectomy. Once the
Yes, sir.
patient responds or the tumor shrinks, just to avoid fungation and ulceration of the tumor. So that
yes, sir.
would be one answer which could be
Uncomfortable.
given.
Yes.
Right. Is there any role for genetic testing of the near relatives? Do you think that's necessary in this lady?
In this patient, sir?
Her children or her siblings?
Yes, sir. Sir, it has to be like genetic testing has a role in it, sir. Sisters have to be.
Yes, certainly, because you're saying it's a very aggressive. Correct. So that's an option which you have to give.
Yes, sir.
What is your role about breast reconstruction? What is your thinking about breast reconstruction? Suppose a patient asks you,
Yes, sir.
what would you like? How would you manage? How would you answer?
Sir, we can plan for oncoplastic surgery, sir, where there is both oncology principles and plastic surgery principles which are combined together, in which there is adequate removal of the malignancy along with reconstruction of the breast, sir.
So these are questions which may be asked in your exam.
Yes, sir.
And basically, the reconstruction can be immediate or it can be delayed. Delayed in the
Yes.
sense that after you finish everything, after your chemotherapy and
Radiotherapy and
radiation.
radiotherapy. Yes, sir.
So generally, a delayed reconstruction is preferred.
Yes.
Because you don't want a recurrence if you put a very early, if you do a reconstruction early. So these are questions which could be asked.
Yes.
And they may ask you what are the ways of reconstruction or what are the methods possible. Also remember that you need to counsel the patient regarding the surgery and the prognosis. I think that is also important.
Yes, sir.
Dr. Preethi, Dr. Madhu, would you like to say anything else?
So how will you follow up the patient now? Your patient, you have done surgery, chemo, neoadjuvant, surgery then?
Sir, after surgery, we would like to get repeat scans done, sir. Every
hormonal therapy.
Yes, sir.
You are negative, no? Your patient is negative.
Hormonal therapy is negative.
So there is no role of
A hormonal treatment, sir.
So okay. Now what you will do now? How will you follow up the patient?
So regular follow-ups every 6 months with ultrasonogram can be done, sir, to look for any recurrence. Clinically,
any other recent advances, any recent drugs for triple negative patients where hormonal therapy is not sensitive? Oral drugs.
Sir, triple negative. Sir, okay, triple negative. Sir, CDK9. Sir, drugs like everolimus and CDK9 receptor inhibitors.
Sorafimab, I think.
Oh,
4 mg BD.
yes, sir.
If there are no further questions, can we go ahead with the next presentation? It's
Okay,
almost
okay,
9 o'clock now.
Yes.
Okay.
Thank you, Dr. Manoj. I think that was a good presentation. You have prepared your case very well.
Yes.
Good
Thank
luck.
you.
in your exams.
Thanks.
Manoj,
Yes, sir.
Manoj, good presentation.
Thank you, sir. Thank you, sir.
Okay.
Thank you.
Thank you, Manoj, for the wonderful presentation. All
you,
the
ma'am.
best for your future.
Yes.
So
thank you.
we now have the next presenter, Dr. Sagar from Mysore Medical College. He will be presenting on a case of a swelling in front of the neck. Dr. Sagar, please share your screen. Manoj, Dr. Sagar, please share your screen.
Is it visible?
Right. Yeah. Please present.
Sir, can you go on full screen mode?
Good evening, ma'am. Good evening, everyone. Myself, Dr. Sagar, a final year postgraduate in Department of General Surgery from Mysore Medical College and Research Institute. Today, I am presenting a case of Mrs. X, 37-year-old female, hailing from Belgola, Mysore, homemaker by occupation, belonging to lower middle class, according to modified Kupuswamy classification. She was admitted on 26th of May 2025 and examined on the same day. She came with complaints of swelling in front of neck since 1 year. History of presenting illness. Patient was apparently well 1 year back. Then she noticed swelling in front of neck, which was insidious in onset and started as a 2x2 swelling, which gradually progressed to present size of 4x4 centimeter over 1 year. Patient consulted a local practitioner for the same complaints 1 year back and was diagnosed with hyperthyroidism and started on tab carbimazole. The swelling is not associated with pain or fever. There's no history of sudden increase in size of swelling. There's no history of dysphagia, dyspnea, and hoarseness of voice. And there's no history of weight loss, eating, excessive sweating, chest pain, and palpitations. There's no history of cold intolerance, weight gain, lethargy, and constipation. No history of any other swellings in neck or elsewhere in the body. No history of headache, seizures, or focal neurological deficits. There's no history of cough, hemoptysis, or shortness of breath. There's no history of bony pains or swellings. Coming to past history, patient is in case of type 2 diabetes mellitus since 2 years on oral hypoglycemic agents. She is not a known case of hypertension, bronchial asthma, epilepsy, or tuberculosis. She gives history of LSC cesarean infection 14 years back, done in view of post-dated pregnancy. There's no history of any irritation to neck in the past. Family history, there's no history suggestive of any thyroid disorders in the family. Allergic history, there's no history of any allergies to any food or drugs. Drug history, she is on tab metformin, glimepiride, and oglibos for type 2 diabetes mellitus, and she's on tab carbimazole 5 mg BD for hyperthyroidism. Coming to menstrual history, she attained menarche at 14 years of age. She gives history of normal and regular 30-day cycle with 3 days of bleed. There's no history of any dysmenorrhea or passage of clots. Coming to obstetric history, obstetric score is P1L1. There's a 14-year-old female delivered by LSCS in view of post-dated pregnancy. There's no history of any miscarriages or infertility. Coming to personal history, she's on mixed diet. She consumes mixed diet. Her appetite is adequate. Sleep is sound. Her bowel and bladder movements are normal and regular. There are no ill health habits. Summarizing the history, 37-year-old female, known case of hyperthyroidism and type 2 diabetes mellitus, came with complaints of painless progressive swelling in front of neck with no pressure symptoms or features of metastasis. Probably a thyroid swelling.
Dr. Mohan and Dr. Madhu, any questions at the end of history?
Yes, sir. 2-3 questions. One is, you said you asked for headache and seizures. Why did you ask this question in your history?
If there is any,
Go back. You written headache, seizures. What is the reason for asking? I was a little confused.
sir, just to rule out any metastasis to CNS.
Very, very unusual. Second question is, you said there is nothing suggestive of nothing suggests toxicity, but the patient is on carbimazole. When it was started 1 year back, did she have any symptoms of toxicity? That is a question which you have not addressed.
Sir, she did not have any toxic symptoms at the 1 year back, sir. She went to some local practitioner just for the sake of swelling, where she got, based on history with what she provided, she underwent some investigations and she was started on carbimazole BD, which she has been through since 1 year.
So there has been no symptom of toxicity at any time.
No, sir. There's no history of any toxic symptoms throughout 1 year.
From his. Lastly, has she lost weight? You said there's no weight loss.
There's no history of any weight loss.
Did you talk about family history? Did you talk about family history?
Yes, sir. There's no history suggest of.
I didn't see that.
There's no history suggest of any thyroid disorder.
Right. Dr. Madhu?
Sagar. No history of fever you asked, no?
Yes.
Why? Pain and fever.
Sir, pain and fever to rule out any thyrotoxic or thyroid storm.
Pain and fever.
Sir, if it's associated with any thyroiditis.
What type of thyroiditis will cause pain?
Sir, Hashimoto's thyroiditis is associated with some kind of discomfort.
Does it? That's only discomfort. Pain and fever.
Decurrent thyroiditis is associated with
we have not seen the case with fever, pain and fever. So your case is in front of the neck, no? Anterior part of the neck. So common swelling, you know it's thyroid. So if it is would have been lateral side, you would have defended. It may be. I am trying to rule out lymphadenitis. Maybe lymphadenitis, pain and fever. Either in thyroid, what are the causes for pain in thyroid?
Sir, if there's any pain, if there's any hemorrhage into the
sudden hemorrhage. Okay, next.
In long-standing case of malignancies, you get pains.
Infiltration to surrounding structures.
Yes, sir.
Okay, past history.
Sir,
come to past history.
There's no patient is a known case of type 2 diabetes mellitus since 2 years, sir, and she's on oral hypoglycemic agents for the same. There's history of LSCS 14 years back, done of post-dated pregnancy, and there's no history of any radiation to neck in past. Sir.
Past means when?
Sir, there should be at least a gap of 10 years.
Minimum
10
years. So, irradiation for what? What history you have asked?
Sir, it can irradiation to any benign disorder such as erythroplakia, leukoplakia, or
No.
Adenoids. Sir.
Those are not practiced nowadays.
Sir, it was practiced.
Treatment for what disease?
Okay. Sir, it's also given for Hodgkin's lymphoma.
Yeah, treatment for early age. In young age, it's a lymphoma. Treatment for lymphoma.
Yes.
What type of malignancy you will get if they are exposed to irradiation?
Sir, usually papillary carcinoma of thyroid is most commonly
associated. Papillary variant. There are high risk of developing papillary carcinoma. Yes. Sir, Mohan sir.
So the only other point I want to add is that sometimes in acute thyroiditis, there could be pain. Now, acute thyroiditis could be very rarely bacterial, sometimes viral. It's called recurrent thyroiditis. So those would be the other causes of pain. On this, in this patient, what is your diagnosis of the history?
Sir, it's a thyroid swelling, sir.
Yes, but do you think it's benign? Do you think it's malignant? Do you think it's toxic? What is your
History-wise, there's no symptoms of any toxicity, and it looks like probably a benign swelling.
All right, proceed with the physical exam.
Coming to general physical examination, here is a 37-year-old female, moderately built and nourished, conscious, cooperative, and well-oriented to time pleasant person. Pulse rate is around 88 beats per minute, measured in right radial artery, with good volume, normal rhythm and character, and no radial or radiofemoral delay. Our blood pressure is around 110 by 70 mmHg, measured in right arm in supine position. Respiratory rate is around 18 cycles per minute, and she is afebrile. She weighs around 50 kgs. Height is 152 centimeter. BMI is 21.6 kg per meter square. There's no pallor icterus cyanosis clubbing edema or lymphadenopathy. Coming to head-to-toe examination, oral cavity examination is normal. There's eye examination is normal. There are no tremors, no cervical lymphadenopathy, no pre-tibial mixed edema. Examination of ears, nails, and skin is normal. Coming to local examination, a patient is examined in a well-lit room with adequate exposure and informed consent in presence of a female attendant. Inspection, solitary horizontally oval-shaped swelling of size 4 cross 5 centimeter is present in lower one-third of anterior aspect of neck towards left side of midline. Horizontally extending from 1 centimeter from anterior border of left sternocleidomastoid to about just crossing midline, and vertically extending from 2 centimeter below thyroid protuberance to 1 centimeter above sternal notch. Surface of swelling appears smooth with well-defined borders. Swelling moves with deglutition. Lower border of swelling is seen. Skin over swelling appears normal. There are no scar sinuses, engorged veins, and visible pulsations noted over swelling. And there are no other swellings noted in neck. Trachea appears central in position. Coming to palpation, there's no local rise of temperature. There is no tenderness present or swelling. All inspiratory findings were confirmed. Swelling is firm in consistency with smooth surface and well-defined borders. And swelling moves along with trachea. Plane of swelling is deep to staph muscles. Trachea is central in position. Bilateral carotid arteries are palpable in normal position. There's no cervical lymphadenopathy. Examination of eye is normal. Percussion, resonant note is heard on direct percussion over aminogram sternae. Auscultation, there's no bruit heard over swelling. Coming to systemic examination, cardiovascular system, S1, S2 is heard, there are no murmurs. Respiratory system, bilateral normal vesicular breath sounds are heard, there are no added sounds. Central nervous system, patient is conscious and oriented, there is no focal neurological deficits. Per abdomen examination, per abdomen is soft, non-tender, bowel sounds are present. My provisional diagnosis, it's a left toxic solitary nodule of thyroid in clinically euthyroid state with type 2 diabetes mellitus.
Dr. Sagar, do you have a photograph of this?
Sir.
Okay. My question or comment is that you have not mentioned about the opposite side. You've spoken about the left side nodule. Is the opposite side also palpable? Sometimes it may not be visible, but when you palpate, you can feel the thyroid lobe. Is this palpable or is it palpable on the opposite side?
No, sir. Opposite
or is
lobe
the
is
isthmus also?
no, sir. Opposite lobe and isthmus are not palpable.
So you should mention that in your clinical findings because your diagnosis might change if the opposite lobe is also palpable, isn't it?
Yes.
Dr. Madhu, you'd like to comment?
So, carotid pulsation in normal position, no?
Yes, sir. Bilateral carotids are
How did you
palpable.
How did you palpate?
Sir, I palpated on carotid tubercle on transverse process of 6 cervical vertebra. I palpated on at the level of anterior border of sternocleidomastoid, at the level of the thyroid, upper border of thyroid cartilage.
Which vessel, which part of carotid you are palpating?
Sir, common carotid arteries.
Okay. So did you check the movement with deglutition?
Yes, sir. The swelling is swelling moves with deglutition, sir.
So lower border is
Lower border is seen, sir.
still you have percussed over sternum, even if it is visible. Why did you percuss?
Sir, to see if there's any lymph nodes. Just to roll out if there's any levels on lymph nodes.
I'm suspecting malignancy. Why did you percuss when you are able to see the lower border?
Sir,
What are the other condition which may cause dullness apart from
one is retrosternal extension of thyroid gland, sir. And second is if there are any metastatic lymph nodes in levels on enlarged levels on
enlarged lymph nodes, mediastinal lymph nodes. Next, any other conditions?
Pertaining to thyroid.
Any gland enlargement? Any glands? Thymoma.
Sir,
Thymoma, lipomas, thymomas. So, have you examined
Dr.
for
Sagar,
toxic signs?
I have to ask you this question.
Examination
sir, you're
for
not
toxic
audible,
signs.
sir.
Sorry, sir, I was not able to.
Hello?
Sir?
Hello?
Yes, sir.
Sagar?
Sir, you are sir.
Examination for toxic signs. Your patient is a hyperthyroidism patient on treatment.
Yes.
Have you examined the for toxic signs?
Yes, sir. I have
you mentioned it here? Your case is patient is on treatment, you are told, no?
Yes, sir.
He is on neomarcazole. Did you examine for toxic signs?
Yes, sir. I have examined for toxic signs, and there are no toxic signs present.
What are the things you have observed, examined?
Sir, one is there's no tachycardia, sir, and there are no tremors, and even eye examination, there are no signs.
So at the end of the local examination, you have to put a separate heading, examination for toxic signs. Under that, you have to mention starting from eye signs. So starting from eye signs, next pulse, periphery, like that, one by one, you have to mention it. So what are the eye signs you are supposed to look for?
Sir, one is lid retraction, sir, and other signs of exophthalmos, Stelvax signs, one Grafe sign, Mobius sign, Joffroy sign, Dalrymple sign, and one Grafe sign.
What are other eye signs, you know?
Kocher's sign, Rosenbeck.
What are other changes may happen in if there is a exophthalmos?
There may be chemosis, sir, edema of conjunctiva, and there in long-standing cases there can be corneal involvement to see if there is any punctate keratopathy also. And also
you may land up with keratitis, corneal ulcers. Then next,
at
stage will be ophthalmoplegia. Ophthalmoplegia. Periphery, what do you want to look? Periphery.
Sir, I examined ants, sir. Ants are exams of ants for whether they are moist or cold, sir. There are no signs of hyper.
Lower limb. Did you look for anything in the lower limb?
I looked for any edema of the lower limbs.
What edema? What edema?
Sir, non-pitting edema of lower limbs is seen in
Pretibial.
pretibial mixed edema.
Pretibial mixed edema. It's a misnomer. Mixed edema. Huh? Why it is non-pitting?
Sir, it is not due to accumulation of fluid. It is due to accumulation of glycans in the subcutaneous.
Okay. Sir, Mohan, sir.
Mohan sir, would you like to ask some questions? I can see you are trying to pose some questions.
Yeah. One is you mentioned so many eye signs, and you mentioned the names of those eye signs. It's also necessary for you to know what they mean. For example, lid retraction or lid lack, rather than all those names, because sometimes the names can be confusing. Abs, for example, is something which you need to know. There is also Nafziger's method of examination to look for proptosis. I think you should know that. And eye signs are classified as mild, moderate, and severe. You should know that as well. As Dr. Madhu was saying, chemosis and loss of vision would be very severe eye signs if they're present. Second question is, you said you looked for a bruit. Where did you look for a bruit? Which part of the gland?
At the upper pole of the glands.
Why? What is the reason?
Sir, usually check at the level of superior thyroid artery, as it is superficial and it is a direct branch of external carotid artery.
Correct. You're right. And it's also a larger artery, superficial, and that's the reason why you look for a bruit at the upper pole. So, is there a bruit in this lady?
No, sir. No bruit was heard on.
All right. So, can you go to your diagnosis? Your last slide. So, according to you, it is a toxic solitary nodule. That is what you're trying to tell us. Although there are no symptoms and signs of toxicity at any time. Am I right? Dr. Sagar?
Sir, yes, sir. Sir,
she has been on carbimazole, I know, but even prior to the administration of carbimazole, according to you, she never had any symptoms.
She does not give any history of symptoms apart from swelling 1 year before.
Correct. So I'm not very sure whether you would call it toxic at this moment. Although you've said clinical euthyroid state, it is a solitary thyroid nodule, euthyroid state clinically now. Okay, all right. Past history of query toxicity is what you can say. Doubtful. We don't know. Isn't it?
Yes, sir.
Proceed. How would you investigate? How would you manage?
Sir, I would like to get a thyroid function test done, sir, as a first specific investigation, and see whether there is hypothyroidism. And based on it, I would like to get ultrasound neck done, sir.
Do you have the result here, the thyroid profile?
Sir, thyroid function test, sir. Sir, I haven't uploaded, sir, but it was normal. Sir.
So the thyroid profile is normal.
Thyroid profile is normal. Sir.
How would you after the thyroid profile is done?
Sir, as the thyroid profile was normal, we got an ultrasound neck done, sir, which showed nodules in.
Can you tell us what you look for on ultrasound? What will you look for on ultrasound of the neck?
Sir, we'll
what
see
information?
Sir, we'll see if there are any nodules. We'll see for any. We'll see for vascularity of the gland, and for any lymph nodes, enlarged lymph nodes, sir. If there are nodules present, we would like to get more information regarding that based on the composition, echogenicity, and other things.
Correct. So therefore, you look at the echogenicity of that nodule. According to you, it's a solitary nodule. So you want to know whether it is solid or cystic. I think that is the most important part of your scan, in addition to what you said. So what is the report in this patient? Is the opposite lobe enlarged? That is another information you'll get on ultrasound.
Sir,
Are there any nodules on the opposite side?
There's a single solitary nodule even in right lobe, sir. There's a well-defined nodule measuring 14 cross 12 mm with spongiform appearance, wider than taller in right lobe, sir. The given it as thyroids 1. In left lobe, there's a well-defined solid nodule, 22 cross 13 mm, wider than taller, isoechoic. And there's also another nodule, sir, measuring 23 cross 20 mm, which is solid cystic in appearance and wider than taller with no calcifications.
What's the scoring now? Thyroid scoring. Left
Sir, thyroid scoring, here they have given it as 3, sir.
Now, what is your opinion regarding our scan? What you will suspect?
Sir, thyroid 3 is mildly suspicious of. So we'll like to get one FNSC.
So what are the suspicious features you are able to?
Sir, one is taller than the nodule is taller than wider, sir. Here they have given it as isoechoic, sir. If it was hypoechoic, or if margins were ill-defined, if there were any microcalcifications, it would have suggested of malignancy.
What about vascularity? Any mention about vascularity?
Sir, vascularity of gland is increased in cases of malignancy.
No, here in your case, what's the
here the given it as normal vascularity.
Normal means?
Sir,
when you suspect benign, when you suspect malignant, based on vascularity, benign and malignant.
Sir, if there's increased vascularity, it points towards malignancy.
Where increased vascularity?
At the site of nodules, intranodular.
Within the nodule, outside the nodule. Two things are there.
Sir, within the nodule, if vascularity is increased, it points towards malignancy.
Suspicious of malignancy. Okay.
Malignancy.
So intranodular, it is benign. So you have to look for that also in your scan report.
Okay, sir.
The other important feature of cancer is the solid mass. They've written that it's a solid lesion. So that would also indicate that there could be a malignancy. Remember, the cystic lesions are less likely to be malignant. So that is the usual teaching. So what was the FNAC report? You said you will do an FNAC after this?
Sir, FNAC report showed as a nodular colloid goiter, so in left lobe. FNAC was taken from left lobe, from the swelling, sir. It showed it as a nodular colloid goiters.
On the left side?
They have mentioned it as aspiration was done from left lobes.
Right. So what is your impression now with these reports?
Benign. Sir, left nodule of thyroid. Sir, with
Sagar, we are not able to hear you properly. Please check your network. Sagar, we are not able to hear you.
Am I audible? Am I audible?
Yeah. Now you're audible. Please continue.
Sir, as the report, there are.
You're not audible,
No.
Sagar.
Your answers are interrupted. I think he is disconnected. We'll just wait for a few minutes. So meanwhile, there is one question in the chat box. Should the diagnosis be quoted as treated toxic solitary nodule thyroid presently in euthyroid state?
I think that would be a better diagnosis because we according to Sagar's history, there was nothing to suggest toxicity
sir.
even in the past. So
Past
he can
history,
put a
or-
question mark there and say that doubtful toxicity in the past, and presently the patient is euthyroid. That would be accepted. Dr. Madhu, would you say the same thing?
Yeah, it's correct, sir. What you said is correct.
Yeah.
So we cannot do, presently the patient doesn't have any symptoms or signs of
Yes.
toxicity.
Never had.
Okay.
And I think I would like to stress that a T3, T4, TSH should be done before any invasive investigations, especially if there is doubtful toxicity. FNAC should be done much later, only if the thyroid profile is normal.
I just spoke to Sagar.
Sorry,
Yeah,
sir.
he had some issues. He's joining back now. Yes, Sagar, please continue. Sagar, we are not able to hear you.
Ma'am, am I audible, ma'am?
Yeah, now you are audible. Please continue.
Sir, based on report, there are nodules in both lobe of the thyroid gland, sir.
Okay. FNAC is colloid.
What is your diagnosis now after the reports?
Sir, it's MNG, sir. According to reports, it's a multinodular goiter in euthyroid state.
Correct. So although clinically you thought it was a solitary nodule, on the ultrasound there are nodules on the other side as well, multiple nodules on the affected side. So your diagnosis would be multinodular goiter. Euthyroid status is correct. Other investigations you have in this patient, how would you proceed with this patient? How would you manage?
If possible, I would like to get one radioisotope scan done, sir. As it is, as the patient is on treatment for hyperthyroidism and there is an enlargement of the gland, to look for any uptake within the gland. And based on it, I would like to go with further management.
What you want to do now?
So, so you want to do a radioactive isotope uptake and you want to look for what is called an autonomous thyroid nodule. Is that what you're looking at?
Yes, sir.
Sagar?
Yes, sir.
Yes. Okay. Although the T3, T4 profile is normal, you're suspecting that clinically, is it?
Yes, sir.
What would be the findings on radioisotope scan in such a situation? Suppose there is an autonomous toxic nodule. What would you find on the scan?
Sir, there might be increased uptake compared with the rest of the glands, sir. Or it would be same as the rest of the gland, or it could be decreased compared with the decreased uptake compared with the rest of the gland. There are three.
With reference to an autonomous toxic nodule, remember that it would be a hot nodule. You can't say that it will be a cold nodule. It will be a hot nodule, and there is suppression of uptake of the rest of the thyroid. So the rest of the thyroid will not take up the radioiodine. It will only be the toxic nodule which takes up the iodine. You understand? So do you have that report with you?
No, sir. As facilities were not available in our hospital, we were not able to get it.
Okay. Okay. So presume that that is normal in the sense that it's a warm nodule and that there is no autonomous thyroid nodule on radioactive isotope uptake. How would you proceed?
Sir, I would like to go ahead with surgery, sir. As the patient is in euthyroid state, I would like to go ahead with as there are multiple nodules in both in multinodular goiter. I would like to go ahead with the total thyroidectomy in this.
What are the preoperative investigations which are required in this patient?
One is I would like to get one indirect laryngoscopy done, so to look for vocal cord mobility, and we have done thyroid profile is normal, sir. What we done, and basic investigations like our complete blood profile, liver function test, renal function test.
Yeah, an X-ray of the neck also may be helpful. Although you said clinically that the trachea is normal, that there's no deviation. It's always good to do an X-ray of the neck, two views, AP and lateral. What are the signs on an X-ray which might indicate cancer?
Sir, if trachea, if there's covered trachea, it indicates infiltration into.
No. Calcification. Sometimes you will see microcalcification in papillary carcinoma, and that would be a feature of cancer. But there are other reasons why you do an X-ray as well, not only to look at the position of the trachea, look at the lesion as well. So you should mention it as one of the preoperative investigations, other than ideal. Okay? So proceed. Dr. Madhu, would you like to comment?
Sagar?
Yes, sir.
Do you want to give option of radioiodine? What's the age of your patient?
Our age is 37 years.
Yeah. You don't want to discuss treatment options available?
Yes, sir. I would like to discuss both surgical and radioactive options with her, sir.
Which is better, surgery or radioiodine?
Sir, since she's a middle-aged female, and as there are nodules in both the lobes, and it's a benign condition. When a radioactive iodine can be.
So if the patient is willing, it's better because morbidity, you can avoid the surgical morbidity. So many morbidities. So only contraindication for radioiodine is
pregnancy.
Now present pregnancy. So how will you proceed now?
Sir, I would like to explain both the options for the patient, sir. And I would like to I would like to provide information regarding both pros and cons regarding both the treatments.
Okay.
So, and
for what drug is used for ablation? What drug is used for a scan?
Sir, for scan, iodine 123 scan is used, sir. For ablation, iodine radioactive.
Half-life?
Sir, half-life of iodine radioactive iodine 123 is 12 hours. For iodine 131, it's 7 to 10 days.
Now, what's the present still shorter life drug is used?
Sir, technetium 99 is the recent.
What's the half-life of that drug? 6 to 8 hours, I think. Technetium 99. Now they're using technetium 99. So post-operative, how will you manage after surgery, after total thyroidectomy?
Sir, in this case, as it is a benign condition, uh, uh, we'd like to follow up with the ultrasound like every 6 months, please.
Yours is a simple benign, no? Treated hypothyroid, you are telling. How will you?
Sir, I would like to get thyroid function test done after 4 to 6 weeks.
Why you want
And
to wait so much?
To see whether a patient develops hypothyroid, if there are still any remnant thyroid hyperfunctioning.
So you have to wait. So you have to look for the development of hypo symptoms. Then you follow up the patient by estimation of the thyroid function test. Then what you want to do? Thyroxine, how much you want to start? What therapy you want to start?
Sir, I would like to start a thyroxine replacement therapy. Start with 100 micrograms of thyroxine.
Okay, okay. So in surgery, do you have any?
Dr. Sagar. Sorry.
Sagar?
Yes, sir.
Doctor, you will be asked about complications of thyroidectomy in your exam. And therefore, you should classify the complications as immediate and delayed. And one of the most important complications is hemorrhage. So remember that. Second is, in this particular patient, they may ask you about thyroid storm. So what is thyroid storm and how will you manage, how will you recognize?
Sir, thyroid storm is biochemical and physiological manifestations of excessive thyroid hormones in the body, sir. The present as clinical features of thyroid storm are the fever. There's patient is CNS symptoms like irritability, aggression can be seen, sir. There can be other CNS symptoms like seizures, tachycardia.
So remember that it can even happen intraoperatively. If the patient has not been prepared for surgery adequately.
Mohan sir, we are not able to hear you. Some network issues, I suppose. Dr. Mohan, we are unable to hear you.
Recognize it by the tachycardia, by the sweating, hypotension, and so on. All right. How would you manage such a patient? Is euthyroid? Is such a patient? Yes. Now, can you hear me?
Yes, sir.
Now, can you hear me?
Yes, sir. We can hear you now.
Can you hear me?
We can hear you, sir. Now we are able to hear you, but we couldn't hear the question properly.
I was asking about thyroid storm. I was asking him about thyroid storm because that is a standard question in the exam, and how you would prevent, how you would recognize, and how you treat. And therefore, prevention is to make sure that the patient is completely euthyroid before operate.
Sagar,
The
I'll
next
repeat the
question is, how
question.
would you manage if you recognize it?
Sir, management of thyroid storm, I like to treat with the beta blockers, sir. As the reduce peripheral conversion of T4 to T3 and along with the steroid, corticosteroids, sir.
And adequate hydration as well. So these are the important features of management. So that is a question which you will be asked in this particular case because you have suspected toxicity, and therefore your examiner will definitely ask you about thyroid storm. Okay.
Dr. Madhu?
You said that you...
Yes, sir. Sorry, sir. Please continue.
No, my other point is, why do you want to wait for 6 weeks before starting thyroxine post-op after total thyroidectomy?
to see if there's any remnant hyperfunctioning of the left gland, sir. If there's any left gland.
No, you've done a total thyroidectomy. You said you've done total thyroidectomy. Is that what you said?
Yes,
For a
sir.
multinodular goiter.
Yes, sir.
So
Total
why
thyroid
should you
tumors.
wait? Therefore, there is no residual thyroid. Am I right? So you don't need to wait for 6 weeks. The patient will become hypothyroid anyway. And therefore, you could start earlier. If it is malignant, yes, you may have to wait to find out if there are metastases later. And therefore, you want the patient to become hypothyroid. But in this particular case, it is a benign disease, so you don't need to wait for such a long time to start thyroxine. Dr. Madhu, we want.
Sagar,
Yes, sir.
recent advances in thyroid surgeries.
Sir, minimally invasive surgeries are the recent advances, sir.
Operative procedures, open procedures. Ligation of the inferior thyroid artery. How will you ligate?
Sir, I would like to ligate close near as close as to gland as possible.
Identify each branch. So you have to trace the branch. Earlier, what they used to do? Earlier. So what's the principle? Ligation of superior thyroid artery and inferior thyroid artery.
To preserve blood supply to parathyroid glands, the branches are individually ligated, sir. In superior thyroid artery is ligated close to gland to prevent injury to external laryngeal nerves.
So as close as to the gland. Superior. So what happens if you injure that external laryngeal nerve? What symptoms patient will have?
Patient will have low pitched voice.
Immediately post-operative, what happens? How will you recognize? Next day, you will go to the ward. How will you recognize?
Sir, there will be change in voice, a low pitched voice.
Apart from that, still it's a commoner.
Sir, if
when they take liquids, what happens? Have you observed when you go to ward? They try to aspirate. Why?
Sir, if there is any recurrent laryngeal nerve injury,
not recurrent. Don't want to recurrent. It's not recurrent. For that, why they develop? Sir,
as a superior laryngeal nerve supplies nerve supply to sensory
sensory
above vocal cords, sir. That increases
loss of sensation will be there. Loss of sensation. They try to aspirate. Okay, Preethi.
Mohan sir, any further questions, sir?
No, I would just like to know what happened to this patient in the sense, was she operated or what was the final report? Sagar?
Sir, intraoperatively, there was a palpable nodule in both the lobes, sir. So we proceeded with total thyroidectomy of the.
What was the final histopathology report?
Sir, histopathology report came in as papillary carcinoma of thyroids.
Is it multicentric or was it only the nodule which was showing the malignancy?
It was multicentric. The given HP report was a multicentric follicular variant of papillary carcinoma.
Right. So this is a lesson that, although clinically it appeared benign, so there is always a risk of malignancy in a solid, particularly in a solitary nodule. So it is good that you have operated, you've done a total thyroidectomy. Now, how would you follow up this patient? Now that you know that it is cancer, what will you do post-op?
Post-op, we will like to withhold thyroid supplementation for 4 to 6 weeks, sir.
Correct.
Uh,
What is that beyond that? Beyond that?
Excuse me.
Why should you do that?
Sir, so that
You're not audible.
to increase the TSH levels, sir, so that there is when we get the radio iodine scan done to see for any residual disease, there will be increased uptake.
Correct. So the tissues become iodine avid, and that's the reason why you wait for the TSH to increase. So do you have that report with you in this patient?
Oh, sir,
Not done, I think, sir.
no, not
done yet.
Not done.
The other questions which you may be asked are about hypoparathyroidism after total thyroidectomy. Remember that that is also a common complication. So you should know what are the features of hypocalcemia. You should know when it develops after thyroidectomy, and how do you recognize, how do you manage it? Preethi, he's not audible.
Mohan sir, we are not able to hear you.
I
Can you
was
please
I was
repeat the
asked,
question here?
I was asking him about hypocalcemia in the post-operative period. How would you recognize and how would you manage?
Sir, the earliest sign would be perioral numbness, sir. And there are specific signs like Joseph's sign and Roger's sign, which are positive in hypocalcemia. In severe cases, there may be corporal spasm and tetanus.
What
How would you treat it? That is the second
is the
part of the
treatment?
question.
Sir, I would like to get serum calcium levels done, sir. And based on it, would like to give either intravenous or oral correction supplement.
So remember that if you send serum calcium, it will take some time for the report to be available. You can't keep waiting. So you may have to give the calcium immediately, intravenously. What is the precaution you will take when you're giving calcium? This is another question which you may be asked.
Sir, I would like to get ECG. I would like to give IV calcium gluconate under ECG monitoring.
Correct, correct. And very slowly as well. It's given as a bolus, very slowly, so that you have the cardiac monitor with you. Remember that it can produce cardiac arrhythmias or even the installs. So you should be very careful when you're giving calcium. So these are questions which will be asked in the exam. Also about recurrent laryngeal nerve palsy. What is the incidence and how you manage post-op, etc. These are again questions which you will be asked. Dr. Preethi, anything else you'd like us to add?
Nothing much. I think most of it has been covered very elaborately. Dr. Madhu, would you like to ask any other questions?
Okay, we have completed, I think. Just how you, Sagar,
Yes, sir.
how will you follow up your patient? Papillary carcinoma.
Papillary carcinoma, I would like to follow up with serum thyroglobulin levels, sir. And based on the levels, if it crosses post-op, if serum thyroglobulin levels are more than 0.2, I would like to get repeat radioiodine.
What's the level, normal level?
Sir, it's 3 to 40 nanograms.
30, I think, 30. If it rises above 30, what you will suspect?
The residual tissue or metastasis.
50, if it is 50, it is residual. More than 50 to 100, it is metastatic. So how often you will get it done, thyroglobulin estimation?
Every
Initially, then initially 6 months, once in 6 months, then later on 1 year. Along with thyroglobulin estimation, what other things you want to see when the patient comes back?
we like to get one ultrasound neck done
Yeah,
along with
ultrasound of the neck.
serum thyroglobulin levels and thyroid function tests.
What's the prognosis?
Sir, papillary carcinoma is associated with good prognosis compared to all other carcinomas. There are prognostic scoring indices for thyroid carcinomas.
Number of years survival.
Sir, 20-year survival for papillary CF thyroid is.
Yeah, more than 80 to 90% will survive more than 20 years. It's a good prognostic. Good prognosis. Okay, Preethi.
Sir, there are two questions in the chat box. The first one is, in case of hypocalcemia in the post-operative period, would you like to send parathormone levels as well?
No, since the cause is known, she did not have any symptoms preoperatively. All the symptoms were developed post-operatively. As already cause is known, I would not like to get any parathormone.
What is the opinion of the examiners?
Yeah,
there is a role for PTH assay in the in-op or immediate post-op period. There is a total thyroidectomy. It can, the hypocalcemia can develop a little bit later, but that is a very strong indicator.
Sir, there are network issues, sir, on your side. Dr. Mohan, we are unable to hear you.
So there is a role.
Mohan, sir, we are unable to hear you. Mohan, sir, please check your network. We are unable to hear you.
Oh, I'm so sorry. Now can you hear?
Yes, sir. Now we can hear you, sir.
Yeah. I was talking about IPTH.
Yes,
and
sir.
there
Madhu, sir, what is your opinion on this? We are unable to connect to Dr. Mohan.
Sir?
Regarding
yes,
parathormone levels.
can you hear?
Yes, sir.
There is a role in the immediate post-operative period. Okay, am I audible?
Yes, sir. Now you are audible.
Yes, so there is a role in the immediate post-operative period. If the IPTH comes down, it might indicate later hypoglycemia development. So that would be the only role, not after hypocalcemia develops. In any case, the parathormone level would be low in that situation. So that's my response to Sagar's answer. Anything else, Dr. Preethi?
Yeah, one more question. Where do you keep parathyroid glands after total thyroidectomy? I understand in case of inadvertent injury or removal of parathyroid glands. And if you notice it later, where would you keep the parathyroid glands?
Either in sternocleidomastoid or brachioradialis muscles.
That's all, sir. We had only two questions in the chat box. Any other questions by the examiners?
Okay.
Madhu sir and Mohan sir? Any other questions?
We are covered, I
If
think.
there are... Okay.
I think no further questions. They need to know about the complications of surgery, indications for total thyroidectomy, and so that's about it. And they also need to know what is completion thyroidectomy. That is another definition which they need to understand. Otherwise, I don't have any other comments. Good presentation, Dr. Sagar.
Sagar, good presentation. Thank you for the case discussion. And so we would like to conclude now. But our secretary, Dr. Sarvesha Jaras, and chairman, Dr. Rajgopal Shenoy sir, both are busy in Mandya celebrations. So I'll be concluding the discussion today. First of all, I would like to thank
Dr.
Dr.
Preethi,
Sagar.
Dr. Preethi.
Yes,
Dr.
ma'am.
Preethi and Dr. Naaz here.
Yes, ma'am.
Okay,
Ma'am,
yeah,
nice.
yeah,
I'm glad
yeah,
you're
yeah.
there. Can you
So
please give
I've
your
been there
remarks,
for the
please?
past 1.5 years. I just didn't want to
Oh, I'm
disturb
sorry,
you.
I couldn't see you.
Traveling. So I knew I would have network issues. I have not spoken. So I must say you conducted this session very well, extremely well. And both the examiners really, thank you, Dr. Mohan sir and Dr. Madhu sir for this.
Thank you, madam. Thank you.
Yes,
Thank you,
sir.
madam, for this.
I
Thank
just
you for this
read
privilege.
yes, sir. Thank you, sir. And both the presenters, Dr. Sagar and Dr. Manoj, also did a very good presentation. And it was really a very elaborate discussion. And I also had a lot of learning from this session. Thank you, sir. Thank you, everyone.
Thank
for
you,
this
madam. Thank you.
wonderful session. Thank you, sir.
Thank you, Dr. Sagar and Dr. Manoj, for a good presentation and discussion. And my heartfelt gratitude to Dr. L N Mohan sir and Dr. Madhu sir for obliging to be the examiners. In fact, when I called and requested them to be the examiners, they immediately accepted. And it was a pleasure having both of you here, sir. We got to learn a lot, and we wish to continue this program in further. And in the absence of our secretary and chairman, I would like to thank all of you who are present here, the participants, and all those who posted questions in the chat box, which added interest to the case discussion. Thank you, everyone, for the wonderful discussion.